Well, good morning, everybody, and welcome back to the Georgia Heart Grand Rounds. Thank you all for joining us. We've come together today to hear from a very distinguished cardiologist, professor, and researcher in the field, Dr. Alexandra Lansky. Through Grand Rounds, Georgia Heart and clinicians in the community have access to hear from and meet great leaders and change agents in cardiology, such as Dr. Lansky, and just yesterday, our guest, Dr. Angela Taylor. I'd like to recognize our very dedicated education committee of Georgia Heart leaders who, with their relationships, help to bridge the connection to deliver this valuable education. Thank you, team. Diving right in, I'm pleased to share that today's presentation has been awarded credit for physicians, nurses, and radiologic technicians. This program is brought to you by Georgia Heart Institute with the generosity of grants from our industry partners. The planners have disclosed no relevant financial relationships with commercial interests, and Dr. Lansky will disclose her relationships in her presentation. To claim credit today, please take our survey. If you're viewing online, the link will be in the chat. If you're here in person, you can receive the QR code at the end of this session. Just see Jennifer Reagan outside. If you have a question for the presenters, please hold until the Q&A segment. Online viewers, feel free to drop your questions into the chat and we'll read them aloud at the end. And now, Dr. Henry will introduce Dr. Lansky. Thank you.
Hey, good morning. I just want to give my relevant disclosure that she is my friend and a wonderful human being. But let me just give you a little brief overview. She came to Yale in 2010 from the Cardiovascular Research Foundation, where she was the Chief Scientific Officer for the Clinical Trials Center. And at Yale, she is the director of the Yale Heart and Vascular Clinical Research Program, as well as the Cardiovascular Research Center. She's been involved in innumerable trials of new devices in interventional cardiology and been key in their approval through the FDA, as well as a bunch of medications and other things that just go on and on and on. She has over 500 publications. She is the founding editor-in-chief for the Journal of the Society for Coronary Angiography and Intervention, which has, in the 2 years that it's been out, become perhaps the premier journal in interventional cardiology worldwide. She's well known on both sides of the Atlantic and both sides of the Pacific. So let me introduce Alexandra for you. Thank you.
Okay, good morning, and thank you very much. It's really a pleasure, an honor to be here, Glenn. It's just, all I can say is you're lucky to have him. We miss him up at Yale. I'm not going to try and recruit you back, but we definitely miss you. So thanks for the really nice introduction. So it actually took me a long time to try and figure out what I was going to talk about today. And I texted Glenn, I think it was last week, and I said, what should I talk about? Chronic coronary syndromes or cerebral protection during TAVR. So we chose this topic. It's one that's near and dear to my heart. I've been working a lot on this topic, on this space, if you will, since I came to Yale, so back in 2011, and that was actually the very same time that, as you know, TAVR was approved in the United States. So I'm going to take you through. I'm approaching this more from the clinical trial perspective. So I'm going to be showing you a lot of data evidence where we are, some of the pitfalls in the clinical trials that have been done, and looking forward, what can we expect? So here are my conflicts. I do receive quite a bit of research support for running some of these clinical programs. I'm the principal investigator of the Emboline IDE clinical study that's ongoing currently in the country, Emblok, Boston Scientific, that has the Sentinel device. Most of the devices I'm going to be talking about are not approved, so it's all in the research space. And with the exception of Sentinel, and I think my comments are going to be very measured there. So in addition to the survey at the end of this session, the quiz here, and the most important one for your CME credit, is what is the name of this mountain? I spend my summers, if you see Crouch down there is my now, at the time, little girl, now eldest daughter. She's now 22 years old. And anyways, that's the quiz for the day. I'm going to kick this off talking about trends, mechanisms, and predictors of stroke in TAVR. So again, TAVR was approved in this country in 2011. And you can see the adoption, pretty fast adoption here of TAVR. And in 2014, it was approved for intermediate risk patients. So on that panel over there, you can see, I can probably, let me see here, if I can use the mouse to, can you see that? Yes, okay, great. So in red here are the intermediate risk patients and then low risk patients in black. So as we see over time, we're getting more and more adoption of TAVIs in the country. So this is, I think, a landmark analysis. We're really looking at what is happening in this country. And you can see as of 2018, there were more TAVRs done in this country as opposed to surgical aortic valve replacements. So this, from a patient perspective, from an operator perspective, et cetera, is very appealing and minimally invasive. Shorter time in the hospital, faster recovery, et cetera. And I think most patients would much rather have a TAVR procedure as opposed to surgery. Now, we're here to talk about stroke. And, just right off the bat, I want to say that if we're talking about stroke with our patients, and we're talking about doing a surgical versus a minimally invasive approach, the lowest stroke rate is going to be with TAVR. That has been shown in the randomized clinical studies of low risk, intermediate risk patients. And you can see here in this meta-analysis, this is any stroke, this is disabling stroke. If you want to reduce the stroke risk to your patient, a TAVR is the way to go. So I think this is a good part of the conversation that we need to have with our patients. Over time, we've seen, again, with the adoption of intermediate risk and low risk procedures, we've seen a reduction in the risk of the patient population. There's no question about that undergoing TAVR. What's interesting is when you look at the overall risks of stroke, they've been relatively constant over time. Maybe you can be convinced here that there's a slight drop over time, 2012 to 2019, but relatively constant. In red here is the 30-day stroke rates. It's about 2.5% to 3% overall. And really not much of a change. This is actually out to 12 months, about 4%. And remember, these are stroke rates that are reported by the sites. This is all reported into the TVT registry, or this is based on CMS. So it's all essentially clinically reported strokes. Now, you might think that as operators have higher volume, they have more experience, we would expect or anticipate the stroke rates to come down. In fact, that's not the case. They remain constant. Doesn't matter what the expertise is of the operator, the stroke rates are absolutely constant over time and based on the volume of the operators. Now, we've seen for every other complication, whether it be death, vascular complications, bleeding complications, et cetera, we've seen that relationship with volume and experience and a decline in those complications, not with stroke. So what's going on with that? Let's talk about the mechanism. It's clearly a mechanical issue. When you look at the strokes, overall 30-day stroke rates, half of those happen on day one, and about 2/3 of those happen within 3 days. So it's really clustered around the procedure. And then, of course, there's the tail, and there are some strokes that happen, from day 3 to 5 out to 30 days. But again, the vast majority are going to happen early, and the vast majority of disabling strokes are happening in that very early time frame. So when the surgeons in the room and those who are looking at these valves to say, well, yeah, of course, look at this. I mean, they're degenerated valves, they're very calcified, etc. This is actually really nice, simple work that one of our colleagues, actually, when Glenn was at Yale, Mike Mullen in London, did with one of his fellows, where he basically, in 60 patients, he did transcranial Doppler throughout the procedure to try and figure out when embolization was happening. And as you can expect, it was any manipulation of the valve, crossing of the valve, positioning of the valve, where they saw the most embolization of debris. And, you're looking at this here, but you can see here, these are the two most relevant times during the procedure. So procedural timing, manipulation, anything that's like extending the duration of the procedure is going to increase the risk of embolization. So it is a mechanical issue. One of the other things that we have seen and we saw early that's quite concerning is that when you do diffusion-weighted MRI in these patients, you realize that the vast majority, anywhere from 80% to 100% of patients, will have evidence of brain injury. These are multiple infarcts. So on average, there's about 4 to 5 emboli on the brain detected on brain MRI. And when you look at these areas, the areas of injury, and you kind of like sum them up, you can see that these are not trivial, anywhere from 1.5 squared centimeters to 4.3. So these are pretty large areas of brain injury. Now, we know in the context of spontaneous, so in the neurology literature, we know that these lesions that are detected on brain MRI that may not be associated with an acute stroke, acute symptomatic stroke, longer term are associated with physical decline, depression, dementia, etc. So there are some clinical consequences to this in the longer term. After TAVR, so in the context of iatrogenic embolization and neurologic injury, there is some evidence for neurocognitive decline, and there is evidence that this is actually linked with an increase in the stroke rate. So it's not trivial. We don't quite understand the full clinical extent and consequences of these lesions that are acutely asymptomatic, and this is something that we really need to better understand. So this was a very small study, a registry that we did, 2011, 2012, in patients undergoing TAVR. And all we wanted to do was really to define these lesions, the extent of neurologic injury, based on diffusion-weighted MRI. What we showed was that 94% of these patients had lesions after TAVR. The size of these lesions, the individual lesions, were actually, on average, pretty small, so about 50 cubic millimeters. The maximum size of these lesions was up to about 125 cubic millimeters, but when you accumulated these, when you looked at the total volume, it becomes significant. So in this case, it was about 300 cubic millimeters. So this was just kind of a benchmark of, what's going on and, in terms of the extent of injury. There's been a huge amount of work trying to predict stroke in patients undergoing TAVR. Could we come up with a risk score where we can identify that patient that potentially we could use neuroprotection and prevent stroke? And this has been done time and time again. So there's many predictors, patient factors, as you can see here, and they all stand to reason, like chronic new onset atrial fibrillation, chronic AFib, prior stroke, etc. Many anatomical and procedural factors, as we spoke about. So any kind of manipulation of the valve, valve repositioning, longer procedure times associated with procedure stroke, And then there's a little long-term risk, which is the same risk that we typically think about, but also more calcium in the arch, chronic atrial fibrillation, etc. The challenge is that anytime we've tried to do a risk score, these are so infrequent and so unpredictable that it's actually, we haven't been successful in doing a reliable risk score. So, there's always these debates when you go to the conferences, which patient, should we do it for all? Should we do it for select patient population? And the reality is that we cannot really predict which patients are going to have this complication. All right, a few words on the clinical consequence. I'm not going to ask you to name the flower and what it's called. That's not part of the survey. The consequences. So stroke following TAVR is the strongest predictor of mortality. This is shown again and again. This is from two large registries and meta-analyses. So anywhere from 4 to 6-fold increase in mortality at 30 days if you have a stroke. Now, one of the interesting things to think about is, unlike acute myocardial infarction, where the mortality, the death is close to the event, in stroke, the death happens at a time that is much, as you know, in clinical practice, at a time that's much, further beyond they die of pneumonia and other complications. But this is actually really relevant when, and I'll talk about it in a moment, when you think about how to design your clinical studies and the time point of the assessments. Because if you're looking at a mortality outcome, you really need to look at a longer term measure. It increases healthcare costs. We know in the hospital costs go up, but also fewer patients go home, more patients go to extended care and rehab, and more patients go to nursing homes. So there's definitely a significant cost associated with this complication. And then mild strokes. So again, we're looking at now intermediate and lower risk patient populations. What does it mean to them if they have even a mild stroke? Well, you can see that there's, a meaningful number of these patients will become dependent. There's cognitive impairment, depression, social isolation, etc. So this is clearly meaningful. This is work from Megan Colwright, one of our colleagues, absolutely wonderful work where she's surveying patients as to their perception of what is important to them. In our clinical studies, we always think death is the worst, and then there's stroke, and then there's bleeding and vascular complications, and we have our own hierarchy. But what she's doing here is she's turning this around and saying, well, what patients, what do you think? What's important to you? And it turns out that staying alive for patients is less important than actually being active and being independent and having fewer symptoms. So it's more about the quality of life than it is about staying alive. There seem to be differences between elderly patients and younger patients. Elderly patients, for them, stroke is a fate worse than death. Obviously, for younger patients, they want to stay alive. That's really important for all of us. But also they want to retain cognition and mental acuity. So again, taking this perspective into account, I think, is very important. Okay, I'm going to switch a little bit and talk about sort of an initiative that I led early on in terms of defining neurologic endpoints. So if you look at this, there are many, many different ways that we can define stroke. And this was a problem when I started doing trials in this space, because we need to make sure that trial A and trial B are defining stroke in a similar manner. And what we realized is not only is the stroke definition really important, but the ascertainment of stroke is really important. So having the interventional cardiologist or the structural cardiologist go into the ICU room and say, you know, Mrs. Smith, are you okay? And reporting whether or not a patient had a stroke is very different than if you send a neurologist into the room and they do a full neurologic exam and they're checking absolutely everything and they actually detect significantly more strokes. So what we wanted to do was in this initiative, it's called NeuroArc. We collected a huge number of stakeholders in the space, including interventional and structural cardiologists and CT surgeons. I brought in some neurologists, neuroradiologists, imagers, etc., as well as the FDA. So this was truly a huge collaboration. We had 40 people coming together, and the whole purpose of this initiative was really to help guide us in how to assess, measure, and classify neurologic endpoints for the purpose of clinical studies, so that when we report these at the end of the day, we're all talking about the same thing and we know what we're referring to. So this is just a very nice picture. We met twice. This took actually a year to put into, you'll see there's one table that summarizes everything, but it actually took us a year to pull this together. And this happens to be at the Yale Club, Glenn. I don't know if you've ever been there, but it's a great place to have nice meetings, as you can see. So after a year's worth of work, this is what we condensed down our recommendations in terms of these definitions. Basically, there were 3 categories. The first one, we called it overt or acutely symptomatic stroke. So, you know, this is what you're used to, right? It's the ischemic strokes, it's the hemorrhagic strokes. We wanted to pull out these, particularly in the context of TAVR, the hypoxic ischemic injury. These are patients that may, on the table, you know, have an arrest, have CPR, go to surgery, etc. It's a completely different mechanism in terms of stroke, and we felt that that was really important to kind of pull out. The second type is covert CNS injury. So we called it covert because some have called it silent CNS injury. We called it covert because, again, we don't know in the longer term what is happening with these patients. If they have cognitive decline, if they have more dementia, if they have, you know, et cetera, then we shouldn't really call it silent because, you know, obviously there are clinical consequences to it. But acutely, there is symptomatic, and on imaging, there's evidence of brain injury. And then the third type is neurologic dysfunction. So they have a neurologic symptom, but they have absolutely nothing on imaging. And that includes the TIAs. We always lump together stroke and TIA as if it has the same prognosis. It really doesn't. And delirium. So what I learned during this whole exercise is the delirium, which happens mostly postoperatively, in about 45 to 50% of cases, is actually linked with stroke. So if you do brain imaging in these patients, about 40 to 50% of these patients will have evidence of stroke. And you've got to think about that. And it's not necessarily something that we think about. So when we did this, FDA was like, you know, all on board. This is really important for them because of, you know, what they're trying to sort out in these clinical studies. But they said, whatever you do, you need to be consistent with prior definitions. And that makes sense, right? We don't want to be coming up with something completely new and then all the rates are different. So our definitions are consistent with the VARC, so the Valve Academic Research Consortium definitions. Basically, they look at everything, all the acutely symptomatic strokes, including these more global hypoxic ischemic strokes. And we are consistent with the American Stroke Association definition. So we ticked that box, and I think we met all the criteria. In the document, it was a little bit more lengthy than that and goes into a lot of details of how to do it and what the recommendations are. But we did recommend for neuroprotection trials to use imaging, to use diffusion-weighted MRI as a measure of effectiveness in these types of studies. Why? Because it's more sensitive than looking at just simply clinical symptoms of stroke. So that's that in terms of the neural arc. So let me now switch, and I'm going to talk about the evidence that we have with cerebral embolic protection. So this is the landscape. I'm not sure you realize how many devices are out there that are going to be tested. So the first two here, the Sentinel, I'm sure you're very familiar with it here. I don't know if you use it here. And the TriGuard have been tested, evaluated. This one is approved in the United States and in Europe. TriGuard was not approved in the United States. It was approved in Europe. It's no longer in use. It's no longer being made. And all of these are all investigational. In blue here are devices that you're going to be hearing more about because they're currently being evaluated in IDE clinical studies. And these in brown here are earlier stage and not in clinical studies. So let me go over the evidence and sort of like more the pearls of what we've learned from some of these studies. It's been sort of a challenging space to say the least. So Sentinel, currently manufactured by Boston Scientific, is basically a very simple filter with these two little baskets that go here in the innominate and the common carotid. They leave the left vertebral, so the posterior circulation is left unprotected. I would say that the blood flow to the posterior circulation is probably 10 to 20%, not 10%. So it doesn't provide complete protection. Initial work, single center work that has been pooled in this analysis was fabulous. Huge amount of reduction here in stroke rates. Procedural stroke reduced by 65%. Death and stroke reduced by 66%. Disabling stroke reduced by 84%. Bring it on. This is great. The best device you've seen. It's a miracle device, right? And again, these are all single center studies that have been pooled, and this is a propensity matched analysis. Beware. That's just my piece of wisdom. Beware when you see these kinds of results. So here's our IDE clinical study. So this is the study that was done for approval of this device. 345 patients. They have to show, to get through FDA, you have to show safety and efficacy. Safety was a composite of all-cause death, stroke, and kidney injury, stage 3. And they showed that they were safe. So it was actually compared to a performance goal, but even when you look compared to the controls in the study, it was safe, not worse. The efficacy endpoint was based on imaging, brain diffusion-weighted MRI, in the protected areas. So they sliced the brain looking at only those areas that were protected. They didn't look at the posterior circulation. Let's forget that, right? But sadly, they were not able to show a difference. So numerically lower, not significant. And if you dig into the appendix and you look at the total brain and the diffusion-weighted MRI results in the total brain, there's really absolutely no difference, I can assure you. What they did do is they collected all the debris, and they took lots of pictures. And they took the debris, sent it down to Renu Vimani down in Washington. She did a beautiful analysis. She's the pathologist. She showed that there was debris in all cases. And among the debris, she found some really interesting things. So tissue valve, foreign material from the catheters, necrotic core. So it's really collecting. It's telling you that, during these procedures, as there's friction across the native valve, some very interesting pieces of material are being released. These are the clinical outcomes. So stroke was reduced by about 40%, not significant. It was not powered for that, but about a 40% reduction, non-significant. And a post hoc analysis looking at 72 hours, once again, dramatic reduction, 63%, and let's go for that. Again, not quite significant. Yes, it's a strong signal. And, yes, there's, I think it makes the point that there may be something here and, we need to persevere. It's probably not the best device. Anyway, this goes to panel. So the FDA reviews this and it goes to panel. And as you know, it's approved. And it's interesting. It's a safe device. It was approved. It failed the efficacy endpoint. And Jeff Borer, who was actually one of the panelists, it was actually a majority vote in favor of this device. This is what he says. Intuitively, it seems like a very good thing. Even though I really can't interpret what it means, the images look better when a filter was used than when it wasn't used. And if I had to choose, I'd rather have this thing in than not. And it was really on the pictures and the gestalt that FDA actually approved this device. And here we are. So, and I think FDA to this day is probably regretting this decision because once you have an approved device, that becomes the predicate for everything that comes behind it. I will say it's safe and, nobody's going to contest that, but all right, so that's that. So moving on, the device now is in the hands of Boston Scientific, and they decide to do a large-scale randomized clinical study looking at stroke as the primary endpoint. Well, that's what we all wanted to know. How effective is this device in reducing stroke? They look at stroke at 72 hours. Remember what I told you? Yeah, if you can find my phone and turn it off. Sorry, I can hear that. Remember what I told you about death. So death is going to happen down the road. They looked at their primary endpoint here at 72 hours, period. It was all stroke. And so the first question is Sentinel safe? We saw in the initial small study, it was safe. Now we've got 3,000 patients. And on all counts, it confirmed that it was safe. There's no difference in stroke. There's no difference in death rates. There's no difference in vascular complications, kidney injury, etc. It is safe. So we're comfortable with that. That's great. How about effectiveness? Is it effective? And sadly, again, in their primary endpoint, they didn't meet it. They did have a 20% reduction here in overall stroke rates, but it was not significant, 2.9 to 2.3. So here we are, 3,000 patients down the road with failed study. I mean, that's what it is. However, so the dialogue, the discussion is all around this. So among these strokes, so a component of overall stroke is disabling stroke, and that was significantly reduced by 61%. That seems like a lot. It was an absolute reduction of 0.8%. So here we are. And the question is, how do we interpret this? We love to debate this. Some will say, well, it's a failed trial, doesn't mean anything. It was never pre-specified. Other people, including myself, I will admit, say, well, can we really discount this? Can we ignore the fact that, there's a reduction here in disabling stroke? It's the worst kind of stroke. It's associated with the highest mortality. It's really a problem. And when you look at all the subgroup analyses that they look at disabling stroke, it was so consistent across the board. Every single subgroup, it was reduced. So I think there's something here. To me, the way I interpret this, they failed their endpoint. The benefit is numbers needed to treat to reduce a disabling stroke was 125. It's a huge cost to society, to institutions, etc. So, but to me, the way I interpret this, and I always say this is a first generation device. It's not perfect, but there's a signal here. We know that, if we can only find the device that is not going to be, that will cover all 3 cerebral vessels, maybe we will get there. And I keep on having hope that we're going to be able to reduce this complication. Next in the pipeline here for Sentinel is this huge trial called the BHF. This is a UK-based government-funded study, BHF Protect TAVI, 8,000 patients. Exactly the same protocol, 72 hours. I think they're missing the endpoint. They need to kind of push it out and look at mortality in there, but that's a different story. And then at the end of the day, when the UK study is done, then they're going to pool it with the protected TAVR, and they'll have 11,000 patients, and maybe we will see a reduction in stroke with Sentinel. Question is, what's the numbers needed to treat there, and what is the clinical value? Again, we'll be debating that when we get those results. Prior to protected TAVR, this was kind of like a snapshot of what was happening at institutions in the country. About 30% actually had Sentinel on the shelf. Only about 10-12% of patients actually were receiving the device. My guess is that has gone down. I'd love to hear your opinion, but I'm pretty sure that's gone down since protected TAVR has been done. All right, I'm going to shift over to the work that I've been involved with. It's a completely different device. It's a deflection device. It's a device that kind of sits in the arch of in the roof of the aorta. It covers all 3 cerebral vessels. This was the first generation, pretty flimsy looking device. It had this, what we call stabilizers, this thing that kind of poked up in the innominate, and these 2 things that kind of were supposed to hold in place. This was the first generation. It went to this other updated version that was supposed to be self-stabilizing, self-positioning, and just much better. So we did a lot of work, initial work with the device showing that, again, it was safe. It seemed to have signals of benefit. These are the 2 IDEs. So we did one approval study for the first generation, the flimsy one, and essentially showed, I'm going to cut to the chase here, it was not safe. There were more complications, more vascular complications because it had to have another access. And in fact, had no impact on strokes. It was not safe, not effective. We did diffusion-weighted MRI in every patient. We found something really interesting. I mean, every time you do a study, even if it's a failed trial, you learn tidbits. So what we learned from this is that this device, as flimsy as it was, seemed to reduce the big lesions on the big things that we saw in the controls. We didn't see with the Trigon device. But we tended to see more of the little ones. And that was kind of disturbing. And it raises the question as to, these little spots, dots that we see after the procedure, what do they mean? And I'm going to come back to that because we've done some nerdy work to try and address that question. So that was Reflect 1, didn't work. Reflect 2 was looking at the next generation. And again, you don't need to look at the details, but the bottom line is it wasn't safe. So you can see here composite safety at 30 days, 16% versus 7 in the controls. And again, we failed our efficacy endpoint. It was a very kind of nice hierarchical, looking at win-weight ratios, very trendy sort of efficacy endpoint. We failed it. So on both counts, this device, first generation, second generation didn't work. Lessons learned. Number 1, the device actually didn't stay in place. They would position it there, and then as you come over with the TAVI system, the filter would kind of be pulled forward because they had a little hook on the front end. It would pull forward and then snap back. Every case. Some of them would twist. There was all sorts of issues. I ended up calling it the cheese grater device, because I think it really kind of like described very well what I thought was going on, which was all this movement is actually causing problems. So as we think about these devices, we have to think about the performance. And I think the FDA is really kind of clued into this. But the other observation, again, is that you can see this nicely here, controls treatment. It definitely seems to be reducing the big lesions. So that's good. And it definitely seemed to be increasing. This is like a subset. But overall, when you looked at the overall patient population, definitely seemed to be increasing the small lesions. So again, probably an effect of like all this motion. So as we look at new devices, this is what we need to be focused on. All right, so where do we go from here? Again, I think the FDA is now pegged with Sentinel, and we need to, every other device that's going to come down the pike is going to be compared to Sentinel. And it's sort of like, well, all we need to show is we have a safe device and it works as well as Sentinel, but we're kind of finding out that Sentinel doesn't really work very well. So it's a dilemma. It's a dilemma for the regulators and for those trying to design clinical studies. Payers, CMS, you have to show clinical benefit. So, you're going to have to do the 3,000 patient study and show that there is a reduction in stroke. For doctors, for all of us, well, we want to show that it's beneficial to the patient because we're talking to them, and it has to be cost effective because we have to deal with our hospital administrators, right? And then guidelines. Guidelines are going to need the big randomized clinical studies to show that there is clinical benefit. So again, in my mind, the future is here. It's in the second generation devices. Again, there's a whole host of these coming down the pike. Most of these are currently in clinical studies. I'm very pleased to say that this one, we have, I think, 60 some patients in this study. And again, I'm very optimistic about this particular device just based on the way it works. I'm not going to go into the details of all, how the designs and stuff like that. But I wanted to kind of close out and talk about this, because I think as we're thinking of how do we show that using these devices actually is helping patients, and that's what we have to show. We have to show benefit. We have to show superiority either compared to controls and even, I would say, compared to Sentinel. These are 3 patients. You've probably seen the slide. It's been shown everywhere. 3 patients from the Sentinel trial, all with very different looking brain MRIs. These are actual MRIs. And they all had a stroke. So when we look at these images and we're trying to sort out how to interpret brain MRIs, the lesion size, count, to location, etc., what are we supposed to be looking at? We have 2 failed trials in terms of efficacy using diffusion-weighted MRIs. So we need to better understand this metric if we want to use it as a surrogate. So this is what we are currently working on, and I'm not violating anything. I'm going to be presenting this at TCT, but I thought I'd try it out on this group first. So you're getting the first look at this. So what we're doing here is these are all the trials that my group has designed. So they're all like same methods, same assessment. Neurologists go in before and after up to 30 days. Everybody's getting an MRI after the procedure at the same time frame, using the same protocol, the same core lab, the same adjudication. So it's like the methodology is absolutely consistent across all these studies. And what we have here, the dropout of MRI is very high. As you know, pacemakers, they're too sick, they can't go, etc. So a lot of dropout, sadly, from imaging. But we have close to 500 patients here that have MRI, and 97 have clinical follow-up. So this is the largest data sets with, all these assessments being done in such a consistent way. So isn't this a rich data set to be looking at our surrogate endpoint and trying to figure out what it means? So very high level. in this cohort, we have 33 strokes, 6.9%, 7%. Fatal disabling stroke is about half. Interesting, we looked at stroke recovery. So 6.6% of these 6.9 actually recovered, 4% completely and incompletely, 2.5. MRI lesions, 85% had injury on MRI, and you can see here based on different thresholds, the volume down here, and this is just on a per patient basis. So up to 500 cubic millimeters in about 10% of patients. That's still a lot. Okay, so that's the background. So now we're trying to slice and dice to try and see if brain MRI can actually predict stroke. That's the big question, right? So this is simply looking at the total lesion volume for patients that did not have a stroke versus in red, those that did have a stroke. So the first thing that jumps out is stroke patients have bigger lesion volumes, right? And that's good. So there is kind of like these curves do split. The problem is down in here. And what do we make of these small lesions, which is kind of like, the whole issue. These devices seem to be causing more, and, we need to better understand the implications. So I'm going to go in a little bit of stats here, but we looked at ROC. So as you know, our ROC, the area under the ROC curve, is basically a statistical method to see whether that measure can discriminate between events and no events, right? So what we're looking at here is the number of lesions, the individual lesion volume, and the total lesion volume. Any area under the curve that is between 0.8 and 0.9, that's just the stats behind this, means that you have excellent discrimination, all right? So we're looking at areas under the curve. So the total lesion number here is above 8, individual lesion below 8. The best is the total lesion volume of 0.84. So this has excellent discrimination in identifying ischemic stroke at 30 days. We're making progress here. This is really important. We look at the cut points. What is the best cut point to determine highest sensitivity and specificity to determine whether that patient would have an ischemic stroke? And it's about 500 cubic millimeters. That's very helpful information for us. We did exactly the same thing looking at fatal and disabling stroke at 30 days. And again, very same message here. We look at the number, the individual lesions, total lesion volume, and these are all excellent. They're higher thresholds, and the best one is, again, the total lesion volume. We're looking at a threshold here, depending on the method, of about 1,000. That's a big area, but nonetheless, this is really helpful because what this is telling us is that this surrogate endpoint is actually really clinically relevant, and we've never had this kind of information. Again, more stats, I'm just going to sum it for you. Basically, what we're asking here is there a threshold of individual lesions below which we don't care? We can not ignore them. It doesn't make one bit of difference. And in fact, the answer to that question is no. What we're looking here is the odds ratios of ischemic stroke versus the individual lesion volume cutoffs contributing to the total lesion volume. And if you look at these odds ratios, so it would seem like there's an increase, but if you look at the scale here, your odds ratio is going from 1.4 to 1.6, that's nothing. So there's really no threshold. This is looking at the logistic regression of the C statistic. And as you eliminate the small lesions, it goes down. It's actually worse. So you have to look at everything. There is no threshold below which we should be ignoring these lesions. And I think that's important. And final data slide, I promise, this is looking at the probability of ischemic stroke at 30 days based on total lesion volume. And you can see this as you go to increasing lesion volumes, so does your risk of stroke. And again, we're very interested in this area, but again, you can see that it's always going up. So the message that we can glean from this analysis, which is so important for the field, is that any lesion is a bad lesion. And as you go to higher and higher volumes, greater counts, that is predictive of ischemic stroke, and that's a bad thing. So the quiz to you is, what do you prefer? If this was you were having your TAVR procedure, do you prefer this one? You have bigger lesions but fewer, or do you prefer this one? If you had to make the choice, you want multiple lesions, total lesion volume is pretty much the same, right? The answer is you want neither. None of these are good. You wanna get rid of these. So hopefully with all the work that we're doing and all these new devices, et cetera, we'll be able to solve this problem, or at least reduce the problem. So a lot of takeaways, just to sum up without reading these. Number one, I think, again, it's a mechanical problem after TAVR. The rates are consistent. Surgery has higher stroke rates compared to TAVR. I think that's the first thing we can say. In terms of the only device that's available to us on the market, Sentinel, it's safe, effectiveness, we've seen a tiny little reduction in disabling stroke. That's good. That's sort of promising, I think, for the future. There's a lot of second generation devices. And what I ended up with here is, from a trial design perspective, I think we can push and look at injury as a surrogate of ischemic stroke. And now we have the evidence that that is a valid endpoint. Thank you. And I'm happy to take any questions. The quiz. What is the name of that mountain? Do you need to see the picture again?
Mont Blanc.
He got it. He's got it. Congratulations.
Well, that was lucky.
Didn't ask you the height of the mountain.
Oh, I did live in that area for a while.
Okay.
Well, listen, that was absolutely fabulous. You can see that it's such a treat to have literally the folks that take us to the next level, that help us think through, how to design the new trials that we end up using. But let's see if there are any questions from the audience. I know we've got a lot of, see Dr. Giuliano. So Greg is an interventionalist, does TAVR, directs our inpatient cardiology program. Recently
Thanks
joined
for
us from Massachusetts.
an excellent, really scientific look at this data. I have so many thoughts going through my head right now, so bear with me as I try to make this into a question. I will disclose that I'm in the group that would rather avoid a stroke and probably prefer to die than have a disabling stroke. And I think that's relevant to my question. It concerns me that the FDA made a decision based on their gut, and showing the FDA pictures when you have a dearth of data is problematic to have a decision that was made, because I think all around the country we saw patients then being marketed to with a negative trial and then choosing locations where they said, hey, we're going to use Sentinel and we're not going to go to you guys because you're not using Sentinel. That's a very concerning impact, I think, of what happened. And I'm wondering if you think that may have occurred because of either undue industry influence at the FDA, or biases in academic publications of the trial and the interpretation of the trial, and try to parallel that with how we have very strong evidence with distal embolic protection and vein grafts, yet that was just downgraded from a class indication, primarily because people thought it was too hard to use, but we have strong efficacy evidence from randomized trials, yet we have this device approved based on negative data.
Yeah, I think all those points are really important. When FDA is kind of stumped and they review the data and they say, okay, we have a safe device. It's, we don't have any effectiveness. they actually get a panel together, as you know. So they actually sort of take the decision to a vote to external people, and they select those people based, they exclude people that have conflict of interest. So I think that the process for evaluating the evidence is robust. And I think in this situation, it's challenging because you see that there's debris. Patients are in there coming, there's a public forum where patients are brought forward and they tell their story. I came in and I had a terrible stroke, and if that could have been prevented, so I mean, it's the case in stroke. If you're thinking about, I think the reason why it went in that direction is because, again, I mean, it was shown to be safe, and in the off chance that this is actually beneficial, and look at all this stuff that's in there, and I think that's what swayed the panel. So the panel was the one that kind of went to the vote and said, yeah, we approve this. We agree that this should be approved. And that is what goes back to the FDA as a recommendation. So I agree with you. I think we're in a very difficult position now as we look at the new devices. And I can tell you the experience that I had with TriGuard, which as I was living the experience, and I was seeing that this device was actually causing harm, and working with a company that would not let go. And I actually extracted myself from the process because I was ethically absolutely against what was going on. So at the end of the study, you won't see me at that panel. There was a panel for TriGuard. Yeah. And, so it's a problem. I mean, and that's the situation they're in now. And I think that's a very difficult one to deal with. And again, I mean, I think there is probably, if I had to guess, I think at the end of the day, when the UK study is done, we will see a small benefit. I actually believe in the disabling stroke benefit. It's small. So I don't think this device is doing any harm, but I just think that, the cost-benefit ratio is just not there. So.
Well, no, that was a great question. I do want to kind of zoom out a little bit. Mm-hmm. Because I think, a 0.8% reduction in disabling stroke in that trial that was statistically significant. And I think what you taught us today that's pretty alarming, and I know some of our TAVR team is here, is that 85% of the time by diffusion-weighted MRI, you get some embolization. And Glenn and I were chatting that there's a lot of things we do in the cath lab. Now remember, this is lower risks than with surgical aortic valve replacement, but still there are a lot of things we do in the cath lab, even crossing the aortic valve with aortic stenosis. There's lots of data that we cause these microemboli. Mm-hmm. But I think the analysis you showed us, the most recent one, where you've actually looked at that curated data set and say that if your volume of overall debris in the brain is about, we were saying, the size of a sugar cube, a little less than 1 cubic centimeter, whether it's scattered or whether it's local, then you're going to have an ischemic stroke. Mm-hmm. We have invited some of our neurologists in the audience as well, because the brain is a very complex place. So the question is, where the heck does it land and what that area is doing? So there's a lot of complexity there. But bottom line is preventing embolization is good. Yeah. And that's why you're in the space, because one way or the other, we need to kind of keep at it to try to figure out what's going to be safe and effective. That's right.
And it's impossible for these small, startup companies, all the Emboline and all of those, not Me Too devices. I mean, they're some of them are great. What's fun is like when you're really into the detail, you can actually, I can predict. I can say today, I predict which one's going to work and which one's not going to work based on how these things are designed. Whether I'm right or wrong, I think I hope to be around to see that. But I think that none of these devices will come to life if we have to do 3,000 patient trials. So we have to come up with a different way of evaluating it. And I don't agree with sort of using Sentinel as the predicate, because I just don't think it's effective. And I think we need to do better than that.
Well, I don't know if Ronnie, I'd like to know if Ronnie Ramadan's in the audience, because I do want to just take a minute and maybe describe to the audience the multiple steps and how the procedure has evolved. Because you showed that beautiful picture of that kind of calcific aortic valve and the idea of first kind of crossing it with a wire. And then certainly I remember in the early days, we used to pre-dilate. I mean, think about that. And without protection, then you're crunching this thing against the wall, and then you're deploying, then you're post-dilating in order to get a maximal benefit. And I loved your analogy on the vein grafts, right? Because we've kind of lived through this. But has the procedure, Ronnie, evolved to a point where it's sort of simplified in an effort to reduce that stroke risk?
Definitely the procedure has become a lot more efficient than it used to be, like 10 years ago, right? I mean, the devices are a lot more sort of friendlier to use, and we've gotten better doing TAVR, right? So I do think that's probably an element, but like Dr. Lansky said, I don't think that makes a difference, right? Like you said earlier. So operator experience does not really necessarily lead to reduction in stroke. Initially, when the device got approved, we ended up using it routinely on all our patients. And I think the selling point was
that's the Sentinel device.
The Sentinel device, yeah. And then we went through this phase when we started saying, well, let's be more selective and think about higher risk patients, right? So let's do it in bicuspid patients that have a high calcium score in the aortic valve on CT. Those in theory would predict more embolization. Patients that have a valve in valve, so they have more degenerated valves, so those probably will embolize more. Calcified aortas, right? So we start coming up with these reasons to use it selectively, but the data did not support that. So I think most operators that I know, once the trial data came out, really shifted towards not using it at all. We still use it selectively in patients, for example, if we're doing electrosurgery like basilica, right? Because we don't know, in those cases you lacerate leaflets and you cause a lot of injury. So we still use it selectively, but I would say definitely not routinely. We've had, like Greg mentioned, we've had patients that ask for it specifically, and since it's approved, we use it. I think the point that I struggle with is there is evidence that it reduces the volume of embolic events to the brain, right? And that, like you said, even if it's asymptomatic acutely, it should mean something, right? And we've, back in a few years ago, we're actually trying to think about designing a study to look at long-term outcomes of that in terms of cognition. How would it affect these patients? And I think that's a very important question, because I think a stroke probably we're not going to show reduction because the prevalence is low and the rates are low. And even if we do a large number of, patients, like you said, the number needed to treat probably is not going to be, it's going to be questionable. But I do think the long-term effects, 10, 15 years, is all this embolic events going to lead to early dementia, decreased motor function. I think that's going to be the key, especially as we treat more and more younger patients who are low risk, 70s, they're going to live for a long time. So I'm just curious about if you have anything in mind in terms of looking at that specific question, like functional MRIs, neuropsych tests. And the other two more points I would like to add, I know it's a lot, but one is to Dr. Samadi's point, there is data that any manipulation in the aorta invasively, there is embolic events that will be caught if you do an MRI, right? So if you're doing a cath, a complex PCI, a cabbage, angiography, you're going to find it. So that it's probably not just specific to TAVR, right?
No.
So I wonder if looking at these devices from a stroke prevention in procedures that might have higher rates of stroke, like cabbage or some other, would be, something else to look at. And the last question is, you talked about how the stroke rate or the strokes with TAVR, right? It's not just during the procedure, right? You might have it up to 3 days. And obviously, if you have an embolic protection during the procedure going to protect these? So what are your thoughts about the mechanisms of those delayed strokes, and how would you sort of prevent those?
Yeah, all amazing questions.
Yeah.
Okay, so the first one was, take your microphone back. Your first question was, because my short-term memory here.
Well, mine is actually bad too. So
Okay, well, that's good. That makes two of us.
So what was the first one?
Well, let's focus. Because we were also time-wise a little constrained.
Oh, the functional, the cognitive decline down the line.
Yeah, the cognitive one. So we, in all our studies, we did a huge amount of neurocognitive evaluation. It is such a complicated space. The patient population is an older patient population. Most of the tests that you do, you have like what you call a ceiling effect. The patient going in have kind of capped the cognitive, abilities. And it's just extremely difficult to show a difference over time because cognitively, based on age and other confounders, they're only going to get worse. So that's a massive challenge. When you work with the neurocognition PhD folks, which I've done, they come up with tests that take hours and hours and hours to do. And they're really into it. It's like, they draw circles and all this stuff, which is great. But it's really difficult for patients to actually do those. And then when you come to the interpretation, you've got hundreds of independent tests. So we did that. We did that in our first study. And yeah, you're going to find some p-values in there, but that's not science. It's like you need one test, one, way to compare this. And that's not how the brain functions because the brain is really complicated. So I don't think we've cracked the nut as to how to assess
maybe
that.
The brain of structuralists are less complicated.
Maybe.
They're more
Very
like
simple.
or interventionalists in general.
Yeah. But I think your point is absolutely spot on. We need longer term trials to be able to understand what happens long term. If you have a big enough study, I pitched when protected TAVR was happening. I pitched to Boston to include that. And I just wanted like a simple way of measuring. And I didn't know that they were doing 72 hours. I was hoping that they'd do some longer term follow-up. Didn't happen. So that's that. That needs to be funded by government. And that's a tough, it's tough to sell those trials and the expense. So that's number one. You're absolutely right that all procedures have some extent of, and that actually has been well studied. I mean, it's varying degrees. The reason why we're so interested in TAVI is because it seems to be the most rich patient population. There have been some randomized studies in CABG patients. Again, I think it's trial design, but both of those, Mike Mack presented them. I forget the names of the devices, but both failed. They looked at two different devices, but they were looking at lesion counts and stuff like that. That didn't work. And then you made a third point, and I forget what it is.
The time of stroke.
Oh, the time. Yeah, that's actually a really, really good one. So, I work with a lot of these companies, and I always say, when you're planning the procedure, what we should be doing, because of that time delay, we should be leaving that protection device in for as long as possible, right? So typically what happens, you go in, you put your protection device, you do TAVR, and then you yank everything out. And I don't think we should be doing that. I think we go in, you put the protection device in, you do your TAVR, you pull out TAVR, and you sit. And you only pull that out. I mean, I think it's worth waiting. I don't know why we're seeing stroke, at 3 days. It could be that there's an embolus and that's the time to manifestation of the clinical symptoms, or it could be just a delayed embolus. So I don't really know. I mean, or both, is quite possible.
Well, I think there are a lot of other fantastic questions, but I know that we're a little bit over time. So if any of you have questions, please come down and grab Dr. Lansky, and then we're going to go do that little interview session where you're going to capture this. And I don't know if Dr. Ramadan or Dr. Henry or Dr. Giuliano, one of those guys around to help with that. But anyway, thank you very much for an incredible talk. Thanks, Alexandra.